Even today we are going to see this beautiful question. Here we are. The 2-month-old baby is brought to the emergency department due to the progressive worsening floppiness. Yes, as soon as you see the floppiness word, your mind thinks it's a botulism, but it is not. Let's see why. We have to see the buzzwords here. Mainly, this is a hypotonic infant and a large anterior frontal alley, large tongue, reducible hernia, has here's low tone and unable to hold his head erect on his own. What are the other things? It's a very good baby who rarely cries and sleeps throughout the night. Been difficult to rose for breastfeeding, right? And she is a 38-year-old woman and immigrated from the United States with his family. That is all okay. Which of the following is the most likely cause of this patient condition? 2-month-old baby brought to the emergency department, progressive worsening of the floppiness and a poor feeding. Okay, now you read the question, I hope. So many people have answered botulism as answer, but this is not the answer, because botulism mein what you see is honey history will be there. Okay, there is no honey fed to the baby here, or a spores which is from the contaminated soil. There will be spores in that place, so there is no food contamination to the baby. It is assumed that it is properly breastfed, because there is no any other formula feed or anything such like that. Okay, so this is ruled out. Down syndrome, 38-year-old woman. There are features of some kind of any features of Down syndrome can you see in this baby? I don't see anything. Let's see. Galactosemia. Most of you answered galactosemia, but it is not an answer, because galactosemia means it's an enzyme deficiency, first of all, and as soon as the baby is breastfed, the features of lethargy, all those things will be there. But in this baby, we don't see such features, that as soon as the baby is fed is not present. One thing. Another thing is galactosemic patients, there will be vomiting, hepatosplenomegaly, all those features will be there. Jaundice will be there. Yeah, even sometimes jaundice might be there in any baby, like 2-month-old baby. Pathological jaundice would be there. In this baby, we don't know whether the baby is jaundice or not. There is no features as such. There is jaundice, so this is ruled out, definitely ruled out, because there is an enzyme deficiency. Like, what is the enzyme deficiency in galactosemia? This is very important question for a NEET. Galactose 1 phosphate uridyl transferase, right? Galactose 1 phosphate uridyl transferase, that's a deficiency, and it is usually present with the jaundice, vomiting, hepatomegaly, all these will be there. In this patient, it is previously well fed. Till 2 months it was well fed and there was no complaints at all. There was no hepatomegaly at all. So this is ruled out. Hirschsprung disease may, it's an abnormal migration of the neural crest cells into the rectosigmoid colon. So there is a lack of these ganglion cells in the colon segment, which leads to this gastric motility. Gastrointestinal motility will be hampered. So that's why there will be a delayed passage of meconium and everything. Here there is a stools are there. See, there is a stools. We can see the stools. The stools have also decreased, but there is a small and pellet-like stools are present. So this is not a Hirschsprung disease. Okay. So this Hirschsprung disease is also ruled out. And hypothyroidism. Yeah. Congenital. Can it be congenital hypothyroidism? Yes, it looks like it. It is, because see, there is a large anterior frontal lobe, the hypotonic infant, large tongue, reducible umbilical hernia, has low tone. Everything looks like hypothyroidism. Yeah, it is a congenital hypothyroidism. That is the answer. This phenylketonuria is also ruled out, because this is also an enzyme deficiency, and there will be a body odor will be changed, right? There is a typical body odor of the in phenylketonuria, that is like what is it? Body odor, musty body odor. Yeah, you are right. Musty body odor is the feature. Okay. What is the enzyme deficiency in phenylketonuria? Phenylalanine hydroxylase deficiency. Yes, that's true. Phenylalanine hydroxylase enzyme deficiency in this. So this is also ruled out. This is the only thing is hypothyroidism. Why I kept this Down syndrome? Because even in Down syndrome there will be hypothyroidism features will be there. That is why we can be confused with this. But there are no typical features of palpebral fissures, epicanthal folds, and single palmar crease, and all those stuffs are not present. Even then, like even though 38-year-old woman is present, we cannot say Down syndrome just with that. Okay, there are no typical features of Down syndrome given in this patient, and it more likely fits into this option, that is hypothyroidism. So let's see some of the features of this hypothyroidism. Congenital hypothyroidism. As it was there in the question itself, there is a hypothyroidism features like cold skin, delayed meconium passage. In this baby there is a coarse, there is no cry as such. They rarely cries and sleep throughout the night they have given, but usually there will be a coarse cry. If at all the baby cries, it will be a coarse cry, like hoarseness in the voice will be there. So that is there. And macroglossia, there, large tongue, umbilical hernias, this prolonged jaundice. The jaundice is present in the baby physiologically, but this physiological jaundice is prolonged in this baby. And there is one more thing is there will be no goiter. If there is no goiter, then it is because of most common cause of this congenital hypothyroidism. What is the most common cause of congenital hypothyroidism? This is a recent NEET question. It is this thyroid dysgenesis. Thyroid dysgenesis. If in this thyroid dysgenesis there won't be any goiter, because there is no thyroid gland, whereas the goiter comes in. If at all there is a goiter present, then it must be thyroid dysharmonogenesis. Okay, that is one thing you have to remember. How do we investigate this child? Any child who comes, like any child of who is born, newborn, if we measure the TSH hormones, they will be always raised. It is because the TSH hormones are physiologically raised. In first 2 days. Okay, so that is why we do not screen the babies as soon as they born. We screen the babies usually at the day of 2 to 5 days. Screening will be done at 2 to 5 days. Okay, typically at the 3rd day, that is 72 hours after birth, we do the screening. We measure the TSH levels and the T3, T4 hormones. And if we see the X-ray of this patient, we don't do, but if we see the X-ray of this patient, there will be delayed osseous formations, and there will be stippled epiphyses. That's the main feature, stippled epiphyses. The stippled epiphyses. And one more thing is, how do we? This is the diagnostic approach of this hypothyroidism. Is first we have to do the radioactive scan. Okay. The diagnostic approach will be this radioactive scan, and that means like just nothing but thyroid scan. When we do the thyroid scan, if there is no uptake, we see that is the one thing, that is there is no gland. There is no uptake, so no gland. That means thyroid dysgenesis, most common cause. It could be no gland, no uptake, no gland, or gland can be normal, that is why there is no uptake. Gland is normal but there is no uptake, then what could be the problem? Receptor problem. TSH receptor antibodies are present in the baby. Antibodies are present. If they are present in the baby, that means it comes from maternal. Antibodies have traveled to the fetus, and that is showing, that is destroying all the thyroid hormones. That is why baby is showing hypothyroidic features. Maternal antibodies. If it is negative, TSH hormone is also receptor antibodies is also not there, gland is also normal, no uptake, then it could be a receptor itself is a problem, or iodine trap, we say iodine trapping, we can diagnose that, right? Or in case sometime what happens, there will be increased uptake. Let's say there is an increased uptake. What could be the reason of increased uptake? As I said, disharmonogenesis. Disharmonogenesis. Goiter will be present. Or there can be a ectopic uptake. Name itself says that is ectopic thyroid gland. Okay, how do we treat the baby? Usually give the supplements of thyroid hormones, like 10 to 15 micrograms per kg per body weight per day. 10 to 15 per kg per day we can give. And how do we assess that is the treatment is successful or not? By again using this thyroid profile again, by that increase in the T4 hormone by 1 week, or normalization of the TSH by 1 month. Okay, normalization of TSH by 1 month, increase in the T4 hormone by 1 week. That is how we see that is there is normalization of the gland. And we also adjust the dose according to the thyroid profile. Lifelong thyroid supplements can be required in some babies. We should see further. That is about the thyroid congenital hypothyroidism for now. And see, this is a very good question. This is like an inicet pattern also, and this is actually a question of usmle pattern, and all these options are also very important topics for NEET. I have to read all these topics. These are important for NEET exam and inicet as well. And if you have any doubts and queries, you can message me in the group. Thank you for your patience.